Over to you, Hilaire.
Okay, thank you, Amarashi. Good morning, colleagues. Can you all hear me? Can you hear me?
Loud and clear.
Okay, thank you. So, good morning, colleagues. Good morning, everybody. It's my pleasure to welcome you all to this webinar on GPS. So, without any further ado, let me just give the floor to Prof. Andre Peter for his welcome remarks before we get started. Over to you, Prof. Peter Andre.
Distinguished participants, ladies and gentlemen, it's a privilege to open this webinar on the meningitis disease caused by Herpes streptococcus in the WHO African region on behalf of the Director of Communicable and Non-Communicable Disease in the African region. Meningitis is a devastating disease which a high case fatality rate, which can lead to serious long-term complications. An estimated 1.6 million cases and over 236,000 deaths were reported in 2019 worldwide and across all age groups, with 1 in 5 affected individuals living after the acute phase with long-term disability sequelae. Despite significant progress made in combating meningitis over the past 20 years, including bacterial meningitis epidemics, it remains a major public health challenge, especially in African regions. During the 71st Regional Committee held in August 2021, member states endorsed the regional framework to defeat meningitis by 2030 that envisions to make Africa free of meningitis by 2030. And it was officially launched by WHO Regional Director in September 2022. And the scope include Herpes streptococcus or Streptococcus agalactiae. Also, the acronym is GBS. The others are Nigerian disease, Streptococcus pneumoniae, and Haemophilus influenzae. The objective of this webinar is to strengthen surveillance, laboratory confirmation, and care capacity for meningitis caused by Herpes streptococcus in the WHO African region, and the expected outcome are, after this webinar, countries will have a group of health personnel who will be knowledgeable in their specific orientation and area of work to understand detection and management of meningitis caused by Herpes streptococcus and future direction in Africa. I wish to all fruitful webinar. I declare this webinar on meningitis caused by Herpes streptococcus open. Thank you for your kind attention.
Okay, thank you, Prof. Thank you, Prof. Now, before we go further, let me just remind everybody some rules that we all need to follow, to comply with before, so that, we get a successful webinar. So some very simple things. First, to start, in WHO, any meeting should be used to harass anybody, in particular sexually. So this is really important for us. We will not accept any sexual misconduct. So in any meetings that we have in WHO, this is really important. So we use, to remind everybody of this fundamental principle, right? So we count on you for that. Now, some technical things for you to know. If you want to ask a question, please raise your hand, as you can see, on the screen. It is very important. And then your camera will be disabled and your mic too, and you'll be able to ask your question, okay? Now, it's very important. If you want to ask a question, please put your question, in the Q&A icon, as you can see here. You put it for technical questions related to the topic we are talking about today and all the presentations. If you are confronted with any issues, with IT or logistics, please, you raise it here in the chat so that we can address it. But if you have any questions related to the topic, please ask your question to the icon that you can see here, right? So the next is for interpretation. You can see the icon here for interpretation. We have 3 languages currently that are available. If you want to listen to French, you click on the French FR, as you can see here, in the Portuguese. It's very simple. I'm sure that you all know this. Now the captions, if you want to read the captions live, you just activate the icon, as you can see. And then we consider that since you have accepted, to join this webinar, you give us permission to record this this session. So this is to make clear that we have the same understanding. And no need to ask for the session materials, okay? It will be shared with you, in the days following this webinar. Okay, and please, we want you to take a subscription to this link that you can see, so that you can follow, the webinar recording. Yes, and please give us your feedback. A survey will be shared later, after this session, so that we collect your suggestions, your thoughts, to always improve what we are doing. Now, an idea of the agenda. I'm done with the rules. I'll come back very shortly on the objectives, but I think Prof. Bita has touched on it already. And then we'll continue with the rest of the agenda. As you can see, Andre Bita will come back again on the regional framework, or we'll see with the panelists if this is still useful to do, because it has been said already 2 days ago. And then Lat Andre will come back, on the epidemiological situation in the region. And then we are going to have Kirsty to tell us about the clinical presentation, the risk factors, the diagnosis, and the treatment. We'll open then a floor to collect your questions and provide you with some answers. After that, Heidi will tell us more about the GBS surveillance guidance, what to do. It is in development, but she will tell us what is there already. And Catherine will also tell us about the lab confirmation on GBS meningitis. And then we'll have, the last presentation of the day, which will be provided by Prof. Andre on the prevention and the control strategies, right, for GBS. And then again, we are going to have a session for questions, and then we'll wrap up. This is very roughly, the agenda we are going to follow today. Well, I wish everybody a good webinar. I hope I did not speak too fast, because I have a natural way to space when I when I speak. But I think you can select the different languages so that you can follow. Now, very shortly, what are the objectives and the expected outcomes of this presentation? Again, it is to strengthen the surveillance, the lab confirmation, and care capacities, on GBS in our African region. This is the general objective. Specifically, we want to improve your knowledge and understanding on GBS. And then we'd like to provide you with an overview on the progress made in countries and the opportunities that are there to further synergize, the vaccination activities as far as the GBS vaccine is concerned. And then one of the objectives we are looking for is to support the surveillance for case detection of meningitis, which is caused by GBS, including the support to be provided to clinicians across the region in identifying, the suspected cases of GBS. And one of the specific objectives also include to strengthen the lab diagnosis for GBS, but also to help you handle, the sample when you are requested to do that, to collect and to transport, to the lab for the testing, but also to improve your understanding, on how to manage clinically, the GBS caused the GBS, the cases of meningitis caused by GBS, and timely comments, the appropriate treatment, okay, in view of reducing the mortality and the sequelae, and especially among neonates. Finally, to raise your awareness and inform the health personnel and policymakers on their responsibilities on detection and the management of the GBS. So these are the objectives I wanted to recall everybody before we continue. So I think the next on the agenda is the regional framework to defeat meningitis. I don't know if we have this presentation, but like I said, it was provided some days before. So I'm still wondering if Lat can guide me. We need to come back to this. Dr. Lat, what would you advise us to do now?
Okay, thank you so much, Hilaire. Yes, you are correct. This presentation was made a couple of days ago during the webinar on meningitis sequelae. But we have some specificities in the regional framework to defeat meningitis in the African region by 2030. So I would like to just shed more light on the GBS component of this regional framework. My name is Anderson Lat. Good morning, good afternoon, good evening, dear participants. So it's a pleasure for me to talk to you again during this webinar. I hope you can all hear me loud and clear.
Yes, I confirm.
Yeah, so let me try and switch on my video. Sorry, I forgot that. Okay, so so this is the presentation of the regional framework, like I said. So that's the outline of the presentation. We had this last time, the background, the epidemiology of meningitis, the vision and scope of this regional framework, the strategic goals, the strategic direction, the strategic pillar, the focus areas, and the perspectives. As a way of background, as we all know, meningitis is a serious infection of the meninge. It is the membranes covering the brain and the spinal cords. So despite all effort that have been, put in place for the past 2 decades to fight meningitis, is still a global challenge, especially in the African meningitis belt. Bacterial meningitis can cause epidemics, which is what we have been experiencing in Africa for many, many years. It can lead to death within 24 hours, especially when there is no treatment, and leave 1 in 5 patients with long-lasting disability. Effort to reduce the burden of meningitis led to the endorsement of the global roadmap to defeat meningitis in November 2020 during the 23rd World Health Assembly. Following this, at Afro level, we have developed the regional framework to defeat meningitis, which was endorsed by member states in August 2021 during the 21st session of the regional committee. And this framework was officially launched by the WHO Regional Director for Africa in September 2022. On the epidemiology of GBS, what we know so far, it is a leading cause of neonatal and infant sepsis and meningitis globally. GBS is associated with maternal sepsis, stillbirth, preterm birth, and can cause disease in immunocompromised adults and the elderly. But the highest incidence of all is in neonates and young infants up to the age of 3 months. GBS disease was estimated to have caused 319,000 cases of neonate disease annually, and result in 90,000 deaths and at least 57,000 stillbirths. The highest burden is in Africa, where 54% of estimated invasive GBS cases and 75% of fetal or infant death. An average of 18% of pregnant women carry GBS globally. So this is the vision of the regional framework to defeat meningitis in Africa by 2030 is toward an African region free of meningitis. And the scope of this regional framework is the pathogen that cause acute bacterial meningitis. There are 4 of them. We have Neisseria meningitidis, we have Streptococcus pneumoniae, we have Haemophilus influenzae, and Streptococcus agalactiae, which is also called GBS, Group B Streptococcus. As you can see, GBS is one of the focus target pathogen for this regional framework to defeat meningitis in Africa by 2030. So these are the strategic goals that are on the left-hand side. The strategic goal 1 is to eliminate bacterial meningitis epidemic. The goal 2 is to reduce cases and death for vaccine-preventable bacterial meningitis. And the goal number 3 is to reduce disability and improve quality of life after meningitis. And the goal number 4 is to build resilience, well-resourced and integrated national meningitis programs in countries of the African region of WHO. So the strategic directions are the following: is to accelerate critical interventions to accelerate meningitis vaccination coverage and control epidemics, upgrade the quality of meningitis case management and care to reduce death and disabilities and improve the quality of life after meningitis. The third strategic direction is to enhance meningitis surveillance and leverage data analytics and evidence to drive progress. And the fourth one is to enhance country ownership, mobilize more financing, strengthen advocacy and partnership and program capacities for defeating meningitis. These are the strategic pillars. There are 5 of them. First one is prevention, epidemic control. Second, diagnostic and treatment. Third, disease surveillance. Fourth is support and care for people affected by meningitis. And the 5th one is advocacy, risk communication, and community engagement. The outcomes of this framework are the following: enhanced access to improved vaccine and effective strategies for prevention and epidemic control, improved tools and access to diagnostic and treatment of meningitis, improved monitoring of meningitis epidemiology through disease surveillance, improved access to support and care for people and families affected by meningitis, strengthen health information and information systems for health, including at the subnational level, and to use this information to inform decision-making. Higher awareness through advocacy and engagement. That's the last outcome. We have developed some milestones on which we report to member states every 2 years. And the first report to member state will take place during the upcoming regional committee, which is scheduled later this year. So the indicators are the following. So we just focus on the key indicators which have been, reported on in the latest report. So this is the strategy logic map for the regional framework. We just highlight the focus areas which touch on GBS. We have the focus area number 6 is to intensify aftercare support for people affected by meningitis. and boost meningitis disease burden and sequelae surveys and studies toward defeating meningitis. So let me just rectify that the report I was talking about was already submitted to the regional committee, which just ended a couple of weeks ago. So like I said, the focus area which are mentioned in this strategic logic map. So the focus area number 2.1 is to improve the quality of clinical diagnosis and treatment of meningitis at all levels of care and strengthen context-specific strategies to reduce sequelae and death. We also have the focus area 2.2 to improve the quality of laboratory diagnostics and antimicrobial resistance, and focus area 2.3, which is to intensify support and care for people affected by meningitis. So each focus area has its implementation priorities. So you can find details of all these in the document of the regional framework. So since this was discussed a couple of days ago already, so let me just end here, and we'll have the chance to have other presentations which focus specifically on the issue of GBS. So just a few slides to give us some overview on the regional framework to defeat meningitis. Thank you so much for your attention.
Okay, thank you, Dr. Lat Anderson. This is quite a lot of information. So again, colleagues, if you have questions, please ask them here on the Q&A button. You just open it and you ask your question there. I've checked, there's no question. Let us stay with Dr. Lat Anderson to present, the epidemiology of the meningitis in the Afro region. Over to you, Dr. Lat. We have 10 minutes, please stick to the time. Thank you. Over.
Okay, thank you, Ile. This is well noted. I hope you can see my slide.
Yes, thank you.
Okay, so I will just share a few slides on the meningitis epidemiological situation in the African meningitis belt. This is the outline of the presentation. First of all, we'll look at the overview of the epidemiology, and then the trend of suspected cases and deaths reported in the belt from 2004 up to 2024. And then we'll focus on what happened during the first 30 weeks of 2024. And then we'll have the reported outbreaks and then the pathogens. So on the epidemiology of meningitis, in the overview of the epidemiology, it's just to recall that meningitis is still a major public health challenge globally, especially in the African meningitis belt, despite all efforts that have been put in place. Meningitis is the second most frequent neurological condition in African subregions due to high rates in West Africa. Before 2010, the most prominent pathogens was Neisseria meningitidis A, accounting for approximately 90% of cases. Following the introduction of the Menafrivac, which is the meningitis A conjugate vaccine in the meningitis belt, the epidemiology of the disease has changed dramatically in our region. So the pathogens that became prominent, the other pathogens became prominent, and in 2023, the most frequent germs that have been isolated are Neisseria meningitidis C, accounting for 57%, followed by Streptococcus pneumoniae, 31%, and Neisseria meningitis W, 3.4%, Haemophilus influenzae around 3%, and Haemophilus influenzae non-B, 1.7%. This graph shows the suspected cases and deaths that have been reported in the belt from 2004 up to week 30, 2024. As we can see, before 2010, on average, the number of suspected meningitis cases that were reported is around 40 to 50,000 a year. And after 2010, like I said, after the introduction of Menafrivac, the number of cases have declined significantly, with on average 19 to 20,000 cases reported each year. As we can see, even the case fatality ratio has declined over the years, moving from around 10% up to below 8%. So we should just note that the majority of cases of meningitis are reported during the first 26 weeks of the year during the epidemic season. This is illustrated in this graph for 2024, week 1 to week 32. Here we have just a mapping of outbreaks that were reported in the meningitis belt from 2019 up to 2024, so specifically week 32. As we can see, the yellow dotted the district that cross the alert threshold, and the ones in red are the district that cross the epidemic threshold. Just to remind all of us that alert threshold is when a district reported 3 suspected cases in a week for 100,000 population, while epidemic thresholds when this is cross 10 suspected cases in a week for 100,000 population. And for the past few years, the countries that have crossed the epidemic thresholds have like Niger, Nigeria, we have Benin, we have Togo in 2023. So this year we have 2 countries that reported confirmed meningitis outbreaks, which are Niger and Nigeria. So these countries have been supported by WHO and partners to respond to these outbreaks. So this graph shows the pathogens that were identified in the belts, just illustrating that before 2010, Neisseria meningitis A was the main pathogen. The bar in blue. After that, we have NMC, Streptococcus pneumoniae, NMW, and NMX. So it's good to know that since 2017, no case of NMA has been reported in the meningitis belt. So this map shows the distribution of pathogens from week 1 to 30 this year. And countries have taken around 7,000 CSF samples that were analyzed, and out of which we have 1,186 tested positive for meningitis. So these are the list of pathogens that were isolated: NMC, first NMW, second Streptococcus pneumoniae, and other pathogens. Just note that GBS, a GBS case was reported by South Sudan in a neonate, and it was reported from the state of Upper Nile. We also this week learned that in Angola, 2 cases of GBS were reported from Luanda, but this is not reflected in the Afro database yet. So the data team is working with Angola to just incorporate this in the regional database. So this slide, I think that's the last one, is showing the distribution of pathogens for the first 32 weeks of 2024. And just to note that Streptococcus pneumoniae was identified in 14 out of the 17 countries that share the laboratory data. So thank you so much for your attention. That's the end of my presentation on the epidemiological situation of meningitis in the African meningitis belt. Thank you.
Okay, thank you, Dr. Lat. And I think you stick to the time. That's good. I'm seeing that some colleagues have an issue with the sound. Can you please confirm that you can hear me correctly? While I'm inviting now Kirsty to put up a presentation so that we can, yes, be, exposed to the clinical presentation, the risk factors, and the diagnosis and treatment. Kirsty, over to you. But let's make sure that yes, the sound is good. Over to you now, Kirsty. Thank you. 10 minutes too. Thank you.
Good afternoon, everybody. So my name is Kirsty, and I'm based in Kampala in Uganda, and I'll be talking about GBS meningitis presentation and excuse me. So GBS is a normal gut.
Sorry, this not okay. That's good.
Are you okay?
Can you speak louder, please? Because it is.
Is that
Okay,
better?
that's fine now. Yeah, please proceed.
So GBS is a normal gut commensal that can asymptomatically colonize men and women, but it causes a problem when women are colonized during pregnancy. In the case of a pregnant woman, GBS can ascend into the uterine cavity where it can cause chorioamnionitis or maternal disease, or it can it's associated with preterm labor and intrauterine. If the baby inhales secretions that are infected with GBS during or prior to birth, then the baby can suffer from pneumonia, sepsis, or meningitis by GBS. And at the farthest end of the scale, neonatal encephalopathy. We also know that babies can be doubly vulnerable if they're born preterm and are exposed to GBS, as well as stillborn babies. And in the absence of interpartum antibiotic treatment or the recognition of GBS in labour, approximately 1 in every 100 babies will be colonised, and 50% will go on.
Hi, Christy. Apologies. They cannot hear you very clearly, and the interpreters are also having a very hard time picking what you're saying. If you can please move a little bit close to the speaker and use your not the headset. Please use your computer, the sound of the computer, not the headset.
Then you, okay. Hang on. Sorry, okay. So in the absence of intrapartum antibiotics, 1 in every 100 babies will go on to develop group B streptococcal sepsis and meningitis. Is that better?
Very better now.
Okay, great. Unfortunately, you'll now also hear my neighbour who has decided to start repair works. Apologies. GBS meningitis is different to meningitis in older age groups because the high fever, headache, photophobia, and neck stiffness are very difficult for a baby to tell its parents. So babies tend to present more differently and more, and so therefore GBS meningitis is often misdiagnosed because of the myriad other symptoms that a baby can exhibit in the first days and weeks of life. But some of these include temperature instability, inconsolable crying, difficulty feeding, and lethargy with a raised fontanelle in some of the older children. There are some guidelines which the NBirth group, which I know many of you were involved with, to try and identify severe bacterial infection. And these include 6 signs, including difficulty in feeding, convulsions, absence of movement, tachycardia, chest indrawing, or temperature instability. But we know within this diagnosis, it's very difficult to differentiate between systemic infections, congenital infections, and local infections.
And although we know that there are clinically based syndromes such as meningitis, diagnosed via CSF infection, sepsis, which is invasive bloodstream infection, and pneumonia, which is an invasive respiratory tract infection, it's very complicated, especially in the neonatal period, to obtain the samples we need to make a bacteriological diagnosis and therefore to distinguish the different causes, even with great lab facilities. In terms of the current gaps in prevention and diagnosis, as I mentioned before, Group B streptococcus can be identified antepartum through screening, and women can then be given antibiotics when they present in labour if risk factors are present or if the screen is positive. However, that's costly and incredibly impractical in most of the African hospitals with which we work. And so therefore, if you consider a ladder of Group B streptococcal disease, where you have the true cases, which is 100% of all babies affected by GBS that we would wish to collect through surveillance. A number of parents will not seek care, and so there is a care-seeking gap. Further, you will have a coverage of quality, even when a parent assesses care, either because of costs or because of other pressures within the hospital setting. Cases with microbiological samples then reduce that true case burden to around 50%, especially as lumbar punctures are seldom taken in neonates, and in certain cultures it's not acceptable to take a lumbar puncture in a newborn baby. And then for laboratories to correctly identify Group B streptococcus, which is a fastidious bacteria, and we will hear about diagnosis in one of the talks coming up. This is also very difficult, especially in rural hospitals, which just don't have the reagents and resources to be able to identify fastidious bacterium. And even if all of those things are done correctly, parents are very mobile in many of our communities. And so long-term follow-up for survivors of Group B streptococcal meningitis and sepsis is very poor. And therefore, we have very few information on long-term follow-up, although I will show you a little of what we have in the Africa region shortly. So, as I said, for those babies who survive Group B streptococcal meningitis and sepsis, neurodevelopmental impairment is incredibly common. And this is some data from Mozambique on the left, where you can see that infants with GBS meningitis, 50% had moderate to severe neurodevelopmental impairment by 5 years. And of the survivors of GBS meningitis at 6 to 18 years, 10% had moderate to severe impairment. And on the right-hand side, you can see a similar picture for neurodevelopmental outcomes such as locomotor function and language function, where GBS meningitis, which is the light blue square, has far lower neurodevelopmental scores than GBS sepsis or those babies that were not affected by GBS in the white squares. So clearly, we have to move beyond survival and think about what happens to these babies if they survive Group B streptococcal meningitis. And so there are some moves now to consider alternatives to intrapartum antibiotics, which we know is very imperfect. And you will have heard of the Group B streptococcal vaccine, for which the WHO has published the full value of vaccines assessment. And the idea is that this vaccine will be given to women during their pregnancy to act as a 3-for-1. So it will protect the mother from invasive GBS disease. It will prevent intrauterine occurrences of GBS disease, such as preterm birth and stillbirth. And it will prevent late onset disease, meningitis, sepsis, and early onset disease, sepsis and pneumonia in these young infants. And this will have greater impact than any other preventative measures that are currently in place to reduce the burden of infectious neonatal mortality globally. And with that, I'd like to say merci, obrigado, and thank you very much for listening.
Thank you, Kirsty. Merci beaucoup. Okay, now, colleagues, we have now, thank you for, keeping the time. Yes, now we open the floor for the questions. If you have, please raise your hand, and then we'll give you the floor. If you want to ask a question, please raise your hand, put your hand up. Thank you. Some questions have been answered already, you know, in the question and answers. Si vous voulez poser des questions, il faut lever la main et on va vous donner la parole. On a 10 minutes pour ça.
There's a hand here by Dr. Seydou Amadou Traore.
Let me, yes, I can see. OK.
Ok.
Traoré, oui, allez-y.
M'entendez?
Parfaitement, allez-y, docteur.
Ok, merci bien. Je remercie Madame pour sa brève, brillante présentation. Cependant, moi, j'ai des soucis auxquels les contrées ouvrent pour faire une fonction lombaire que les parents, surtout qui n'acceptent pas de faire les fonctions lombaires. Je ne sais pas si c'est d'origine culturelle ou que les équipements sanitaires au niveau de ces zones-là ne sont pas adéquats. Merci.
Docteur Traoré, juste une question rapide. Vous nous appelez d'où, s'il vous plaît?
Ok, d'accord. Je suis le docteur Seydou Amadou Traoré, épidémiologiste de l'OMS au Mali. Je suis souvent dans la région de Caille. Merci.
Merci à vous, docteur. OK. Dr. Numa Koboy Muno, sorry for your name. Please ask your question. La parole est à Numa Koboy Muno. Vous dites d'où vous nous appelez, ça nous fera plaisir. À vous la parole, s'il vous plaît. Over to you. Mr. Numa, can you hear me? You are muted. Unmute yourself, please. Il faut enlever le micro. Il faut activer le micro, s'il vous plaît. Okay, while we are struggling to get the question from Numa Koboy Ilmuno, there was a question asked by Dr. Traore on the lumbar puncture. Who's going to, yes, address this question? Maybe Lat or Kirsty?
I'm happy to answer the question about the preserved CSF samples. I haven't seen the question about lumbar puncture, sorry.
Please proceed.
So yes, I think it's very interesting looking at CSF samples. If there are CSF samples that are available, I know that there are research groups who are trying to understand through PCR whether a proportion of the CSF in neonates is attributable to GBS. And there are other groups looking at the One Health approach because we know that GBS also forms a reservoir in cattle, for example, or in freshwater tilapia. So there is interest from the One Health approach because of the potential risk for antimicrobial resistance of group B streptococcus, although at the moment it's still sensitive to penicillin, which is the main line of treatment. Et si je permets, je peux aussi répondre aux questions de professeur Dari.
Allez-y.
Vous nous avez demandé les facteurs qui favorisent le GBS et les maladies causées par cette dernière, en particulier le méningite. C'est surtout pendant la grossesse que il y a les risques de transmettre le GBS du maman au bébé. Et ça particulièrement quand l'enfant est prématurisé. Mais à part ça, il y a surtout question d'hygiène et se laver les mains parce que c'est une pathogène des intestins.
Merci beaucoup, Kirsty. There's a question in the Q&A button, a question from Salome Solomon. Is Salome Solomon connected to ask a question, please? The question is, I noticed a sharp increase in the number of cases reported last year with up to 30,000 cases. What could have been the cause of the increase? It is asked in the chat. How can you explain the increase observed last year? 30,000 cases. someone to ask this question, to respond to this question? Salomé, Salomon, vous êtes connecté? Are you connected? Maybe to better. Okay, we still have questions from Kakuru because we have time. So may I give the floor to Kakuru Gled to ask the question? Bitario, can you ask your question directly live, please? Kakuru, are you with us? Bitario? If you want to talk, please unmute yourself.
No, Hilaire, they need to raise their hands and be given access to speak.
Okay, because they are not raised. I'm just reading from, the Q&A.
Yeah, if the question is already in the Q&A, we can go ahead with answering it. There's no need to repeat it again. So you've read the question out. Please assign it to a panelist to take it. You're muted. We cannot hear you, Hilaire. You're muted.
Yes, thank you. Sorry. So the question from Salome Solomon is that there was apparently an increase observed last year of 30,000 cases last year. So my first question to Anderson Lad is, can you please confirm this figure first, and then do you have any response to that? Anderson Lad? I don't know if Anderson is still connected because
No, he's not at this moment.
okay, maybe he has an assignment. Okay.
I think part of the reason for an increase in cases is because we're beginning to consider GBS and look at surveillance prior to the introduction of a vaccine. And so I think it's probably something to do with case capture rather than anything else.
Okay, thank you, Kirsty. I think which is understandable. Okay. Okay, Kakuru, if you want to ask a question live, you need to raise your hand. Please put your hand up and then we'll give you the floor. Just raise your hand and we'll give you the floor. Kakuru, yes. Si quelqu'un veut poser une question, qui lève la main. Docteur Sanou, vous voulez poser une question, vous levez la main ou donne la parole. Merci.
Hello, this is Hafiz. I was asking.
Sorry, may I give now? Sorry. May I give now the floor to Kakuru? Please introduce yourself and tell us where you connected from. Kakuru, over to you, please. Thank you.
Apologies, please. That sound is very bad. We cannot hear you. If we can move on to the next presentation and take the questions. Yeah.
Dr. Sanu Sufyan, over to you, please. And then we'll come back to Kakuru. Dr. Sanu, à vous la parole.
Ok. Vous m'entendez?
Oui, parfaitement. Allez-y.
Je voulais juste demander, est-ce qu'on a une idée à peu près du portage du streptocoque du groupe B chez les populations saines en Afrique?
Docteur Sanu, ça coupe, hein,
Quand on sait que
ça coupe un peu. Si vous pouvez aller lentement, peut-être qu'on va mieux vous entendre.
Ok. Quand on sait qu'en Afrique, la communauté est très impliquée avec les bébés, les nouveau-nés, est-ce que le risque ne peut pas venir de la communauté et non pas de la maman?
Okay, let's have a second question and then we'll ask them. Daouda Sempara, à vous la parole, s'il vous plaît. Vous nous dites d'où vous nous appelez. Merci.
Ok, merci bien, monsieur le modérateur. Bonjour à tout le monde. Donc, je suis docteur Daouda Sempara, je suis depuis la République du Congo. En fait, je voulais juste savoir, en matière de prévention, surtout chez les nouveau-nés, quand est-ce qu'on doit faire le dépistage chez les femmes enceintes dans le cadre de la prévention de la méningite à streptocoque du groupe B chez les nouveau-nés? À vous.
Merci beaucoup, Dr. Sempara. Okay, on a deux questions. Kissy, I think maybe you are teased to respond to that.
Je m'excuse, j'ai pas entendu la question.
Oui, l'action de Dr. Sempara, chez les nouveau-nés, c'est bien ça, hein, Dr. Sempara? Chez les nouveau-nés, la question c'est, je pense, quand est-ce qu'il faut détecter? Est-ce que vous pouvez répondre votre question pour Dr. Kirsty, s'il vous plaît? Dr. Sempara, vous êtes là? En tout cas, ce que j'avais compris, la prévention chez les nouveau-nés, comment est-ce qu'il faut la faire? C'est ce que j'avais compris comme question de Dr. Sempara, chez les nouveau-nés.
Ok, merci. Je pense que c'est
Ok,
bon. Ok,
c'est bien
merci.
ça.
En fait, voilà.
Oui.
Étant donné que beaucoup de transmissions se font de la mère à l'enfant, donc je voulais juste savoir, dans le cas de la prévention de cette méningite chez le nouveau-né, quand est-ce qu'on doit faire le dépistage chez la femme enceinte afin de prévenir la méningite chez le nouveau-né? Je ne sais pas si ça a été bien compris. À vous.
Oui,
C'est très clair.
bien compris, merci. Bah, c'est une excellente question parce qu'en fait, personne ne sait parce que la colonisation est pas permanente pendant la grossesse. Alors, il y a par exemple, en Europe, ils testent du 3e trimestre pour le GBS pour savoir si la femme est colonisée ou pas. Mais ça n'empêche pas les enfants nés avant la 28e semaine d'aménorrhée, en fait. Alors, si vous avez des idées pour améliorer ça sera avec plaisir que je peux discuter un peu après.
Ok, merci beaucoup, Kirsty. Il y avait une question de Dr. Sanou sur le taux de portage du GBS. Est-ce qu'on a une idée sur le taux de portage du GBS?
Ah bah, ça, dans la région africaine, c'est un par 1000 nouveau-nés, l'incident de GBS. Mais ça existe très peu de recherches au sujet de ça parce que c'est, comme j'ai dit, il est très difficile d'avoir la microbiologie pour le nouveau-né parce que les plupart des cas commencent le jour de la naissance. Et l'enfant meurt avant qu'on peut prendre le CSF ou la bactériologie.
Ok, merci beaucoup, Kirsty. La main de Augustin Karumba ou Kurumba est-elle levée? Est-ce que je peux donner la parole à Augustin ou Augustine Karumba pour sa question? On a encore le temps. Augustin, si vous m'entendez, vous pouvez prendre la parole. S'il ne m'entend pas, je pense qu'on va peut-être évoluer avec notre session. Heidi, now we are going to listen to you for, the surveillance on GBS. What is the guidance which is in development right now? Heidi, may you please put up your presentation? Thank you.
Absolutely.
Please go ahead, 10 minutes. Thank you.
Can you see it all right? Hopefully.
Yes,
Okay. Hello, everybody. I'm very happy that many of you joined us today to hear and discuss about Group B streptococcus. My name's Heidi Suders, and I'm an epidemiologist at WHO headquarters in Geneva, where I sit within the immunization department on a team that focuses on surveillance for vaccine preventable diseases. And so I think as you've been hearing today, it was encouraging to see that 2 countries have begun reporting Group B strep cases to the WHO regional office in Africa. This is great. The regional office just, I think, recently began collecting data from countries on Group B strep cases. And it's great that 2 countries have reported in. And I think that those small number of cases that have been reported in are just the tip of the iceberg. We know that Group B strep is happening in many places across the continent, but detection and reporting is really just getting started, and many places are not doing any surveillance or testing for Group B strep. This is due to partly a lack of awareness, which is something that we're working to start addressing today, but also given what Kirsty said, there are a lot of challenges with doing surveillance for Group B strep, as well as the laboratory diagnostics, which we'll hear more about as well. So we've received a lot of questions from countries recently about what sort of guidance WHO might have for countries on how they can consider or think about any surveillance activities that they might want to undertake for Group B streptococcus. So I'll be sharing today some work that our team is just starting regarding guidance for both surveillance for Group B strep as well as for laboratory diagnosis. And just to mention, we heard at the beginning that about the Defeating Meningitis by 2030 global roadmap. And just to mention that strategic goal 11 of that roadmap is to develop and implement global strategies for surveillance of invasive Group B strep disease, including in low-income settings. So the work that I'll be mentioning really is to address this specific strategic goal and provide some guidance in this space where there is currently a gap. So in case you're not currently aware, our team puts out vaccine preventable disease surveillance standards for each of the vaccine preventable pathogens. And here are just a few examples here of other invasive bacterial pathogens for which we do have surveillance standards in place already, and the links at the bottom of the screen in case you'd like to look at those later. But we have guidance already in place for how countries could consider implementing surveillance for meningococcus, pneumococcus, as well as Haemophilus influenza. So we're hoping, and we're starting the work now to develop similar guidance specifically for Group B streptococcus that we're hoping will come out either later this year or maybe next year. And these surveillance standards really serve to provide guidance to countries in what they could or should be considering in either establishing or improving existing vaccine preventable disease surveillance. And then countries can take these surveillance standards and adapt them as needed based on their local epidemiology, vaccine policy, any disease control objectives, as well, or disease control strategies. And these surveillance standards documents include a lot of different elements of surveillance, including a brief description of disease and vaccine characteristics, any rationale or objectives for surveillance. And I think for Group B strep specifically, the primary objective for surveillance right now would be for countries to consider in advance what data that they would need to inform national decision-making once a Group B strep vaccine is available for decision-making. So that's really our focus right now, is making sure countries have time to think about what data they might need to inform their national decision-making. And then if that does involve setting in place some surveillance, then providing guidance about what that surveillance could or should look like. So this surveillance standard would also provide information on the type of surveillance recommended from WHO to most countries, as well as then going into all of the specifics on case definitions, investigations, specimen collection, laboratory testing, etc. So this is what we are currently starting the work on to develop for Group B strep, and we'll look forward to circulating that and making sure that it's available and useful for countries moving forward. And then additionally, our team is also working on, many of you may be familiar with this, but currently there is a WHO meningitis laboratory manual that's pictured here and also linked at the bottom of the slide. And this manual The current one covers Neisseria meningitidis, Streptococcus pneumoniae, and Haemophilus influenzae. And this manual is well into the process of being revised for these 3 pathogens, but also in this new iteration, Group B strep will be added to it. So it will cover all 4 of these pathogens that are the target pathogens of the Defeating Meningitis by 2030 strategy. And this new new and updated laboratory manual will be updated with current information on the current diagnostic tools, rapid diagnostic assays, antimicrobial susceptibility assays, as well as molecular diagnosis, including whole genome sequencing. And this will likely come out probably sometime mid-next year. And I have one of my colleagues on the webinar today if there are any specific questions about the laboratory manual. So we are looking forward to finalizing and distributing these guidance documents. We know that we've been asked for them by countries, and we ultimately want to make sure that they are useful for those in countries who look to this type of guidance for support. Thank you for inviting me to share these updates today, and over to you, Hilaire.
Thank you so much. This was excellent. So let us now listen to maybe the last presentation of the day, not the last one, but laboratory confirmation aspects with Catherine. Catherine, over to you, please. Thank you. 10 minutes to you, Catherine. Over to you.
Yeah. Greetings, participants. My name is Catherine Okoy, and I'm a molecular microbiologist. So today we'll be talking about the laboratory confirmation of GBS meningitis, which will just be an overview of the laboratory procedures. And the outline goes like this. There'll be a bit of introduction. We'll look at specimen collection, handling, transport, and storage. And then we'll talk about the microbiological techniques, look at some of the molecular methodologies that are available, and then we go over to antibiotic susceptibility testing, and of course, a bit of concluding remarks there. So, as you've already heard from colleagues who have spoken before now, bacterial meningitis is a life-threatening condition that requires very prompt recognition and treatment. And beyond the newborn period, we have also heard that the most common causes of bacterial meningitis are Neisseria meningitidis, Streptococcus pneumonia, and Haemophilus influenza type B. However, within the infancy or newborn period, we have this bacterium, Streptococcus agalactiae, which is often called GBS, which also belongs to the subgroup of the beta hemolytic Streptococcus, which is now known to be a major cause of meningitis and neonatal disease. And of course, we all know how it causes significant morbidity and mortality rates, especially in West African region where, access to healthcare is some sort of low. And as we are aware, Lehman and Newman, they already completed the scientific classification of Streptococcus pneumonia in 1896. And of course, we know it's a beta hemolytic gram-positive bacterium that tends to form chains. And of course, we are already aware that GBS comprises of 10 serotypes, serotype 1A, 1B, 2, right through to 9. And there are geographical variations within respect to predominant serotypes that occur in invasive disease. And now studies have also shown that the main serotypes that circulate in the West African regions are serotype 2, 3, and 5. And so what is really the role of the laboratory in this? For us, the main thing is to be able to confirm GBS and ensure we determine antimicrobial susceptibility so that we provide the clinicians with the appropriate information to deliver appropriate treatment to their patients. This laboratory data is really important because it guides ministries of health when responding to epidemics, in making decisions about the introduction and use of vaccines, and also for proper allocation of resources according to the needs of the populations. And therefore, you agree with me that a well-trained and equipped diagnostic laboratory is critical for the health of individuals and populations as far as GBS diagnosis is concerned. So right now we'll go over to specimen collection, handling, and transport. So far we know that the best clinical sample for GBS meningitis is cerebrospinal fluid, which is often called CSF. However, we need to do a warning here that lumbar puncture is a very invasive procedure and should only be performed by experienced personnel and under aseptic conditions. So once the CSF is collected, it should be labeled appropriately with the appropriate information, which has to be the patient's name, date, and time of collection, and unique identification numbers. Other information could also be included, which will help to identify the patient's sample as clearly as possible. The CSF needs to be transported to the laboratory within an hour after it's collected. And if the CSF cannot be transported and analyzed within an hour, it should be inoculated into an appropriate transport medium, such as trans-isolate medium, which we'll be talking about in the next slide. However, if delay of several hours in processing is also anticipated, the TI medium is not available, the CSF should be inoculated at 35 to 37 degrees with approximately 5% carbon dioxide, and this should be able to improve, the GBS survival. And so we want to talk about trans-isolate medium a bit more because it's a very important medium for sample transport, especially as meningitis is concerned, and would also be using this for CSF GBS. We all know it's a biphasic medium and can actually be used for transport and as a holding medium, as a growth medium as well. This transport medium should be stored at 4 degrees centigrade, but must be warmed to room temperature before it is used. And after it's been inoculated with the CSF sample, it should be appropriately labeled as described before, and also aseptically inoculated. And upon arrival in the testing lab, the TI medium should be vented and incubated at 35 to 37 degrees with approximately 5% carbon dioxide. And in this situation, we need to observe it daily for turbidity in the liquid phase for up to 7 days. And we've also heard colleagues talk about maternal transmission and the rest, and therefore we can also use pharyngeal swab specimens for GBS diagnosis. And once these swabs are collected, as you have seen shown on the slide, we need to place them into a liquid medium, such as a skimmed milk tryptophan glucose glycerol or AMIS transport medium. And this has to be transported to the lab within 24 hours at 4 degrees centigrade. What we know about this media is they can actually be stored at -70 degrees until analyzed. It is important not to use traditional swabs such as rayon, dacron, and cotton swab because this prevents release of microorganisms and reduce GBS recovery and therefore increase the rate of false negativity. So talk a bit about the isolation, detection, and characterization of GBS. First, we look at the microbiological methodologies that are available now. We can do the gram stain. This is a very inexpensive test. It's also useful as it describes the genus of the bacterium. Here, GBS will appear as gram-positive and chain-forming. We can also look at rapid antigen tests, where we use the Streptococcus group B antigen test on CSF. And then we can also, the first and second tests are presumptive, where we can right away do culture on CSF, on blood specimen, on the pharyngeal specimen, which really are the gold standard for GBS diagnosis. And once we use the appropriate medium, we should find beta hemolytic, catalase negative, and bacitracin resistant colonies, as you find on the slide. We should also note at this point, we have GBS colonies that are non-beta hemolytic, but this form just about 5 to 6% of all GBS colonies, and studies are still ongoing whether they are very much involved in neonatal sepsis and meningitis. Once you have the colonies, you can also confirm as GBS using the Streptex streptococcal grouping reagent. And you can serotype the isolates using the strep B latex antisera. And of course, they store the isolates that you've cultured, which must be pure isolate, should be stored in 15% glycerol broth at -70 degrees until further testing. It is important that for all these tests I've listed here, manufacturers' instructions must be strictly adhered to, and there should be appropriate use of controls to assure that the quality of laboratory results are attained. I would like to talk a bit about the Christie, Atkins, and Munch-Peterson test, which is often called the CAM test, because it's a very useful test in the lab. Once you've gotten GBS, I said before that it's one of the subgroups of beta hemolytic streptococcus. So we have the other streptococcus that can be confused with GBS. So presumptively in the lab, once you have a beta hemolytic colony, you can quickly do this test to differentiate it. Because for GBS, it produces a diffusible extracellular hemolytic heat stable protein, which is the CAM factor, and acts synergistically with the beta lysine of Staphylococcus aureus to produce an enhanced lysis of the red blood cell, as you see on the slide. So the suspected GBS are strict perpendicular to a streak of Staphylococcus aureus, of course, on a sheep blood agar, and a positive reaction appears as an arrowhead zone of hemolysis adjacent to the place where the two streak lines come into proximity. So here on the plate, you see a CAM test positive, which actually has an arrowhead, and then you have a CAM test negative. This test is really very important for distinguishing GBS from other species of beta hemolytic streptococcus. And again, we need to follow instructions of the manufacturers, use appropriate controls to assure quality of laboratory results. And so we dive straight into the molecular tools for GBS. We know molecular tools are powerful diagnostic tools with excellent sensitivity and specificity, especially for those that have been validated for GBS detection. And they provide a complementary tool to classic phenotype-based methods, such as gram stain, the rapid diagnostic test, and even the latex agglutination. And they often enhance confirmation of GBS laboratory results. So for this, we have the conventional polymerase chain reactions, which here detect product at the endpoint of DNA amplification by visualizing amplicons using agarose gel electrophoresis. Here, there's a lot of manipulation, and contamination is often inevitable. We move to the real-time PCR, where in these procedures, you combine amplification and detection in one step through the use of fluorescent dyes. These are more specific tests, more sensitive, and often reduce the potential contamination problems posed by conventional methods. And again, we have the whole genome sequencing, which provides, the laboratorian with full picture of the pathogen. This can be used to delineate GBS strains, as I've talked about earlier, the sequence types, looking at clonal complex profiling, and also give insight to chains and transmission of dynamics, and also predict antibiotic resistant patterns. We know how problematic antibiotic resistance has been in our population. So whole genome sequencing really helps us to answer all the questions as regards this. And I just want to talk about the importance of molecular techniques. Even though we know culture is a gold standard, but we often delve into molecular techniques because the culture methods or the traditional methods are often, a tip of the iceberg, as we can see on the slide. But while the molecular methods will go far deeper, and you can even see that most of the culture negatives that could not be identified because of improper handling, suboptimal transport and storage conditions, or prior antibiotic treatment, this could actually be identified using molecular methods. So it is really critical that even as we look at the traditional methods, especially the culture, which is the gold standard because it will provide us with isolates for susceptibility testing, and for complete subtyping of the isolate, we should also look at the negative samples for presence of GBS using molecular diagnostic tools because of their importance. And looking at antibiotic susceptibility testing is quite important. So for all the GBS isolates that we've gotten from our laboratories, we need to test them for susceptibility to the recommended panel of antibiotics in the region. So we perform those mostly with the Kebi-Bauer methods, as it's often the most simple method we have around. And then we confirm using the e-test for resistance or intermediate sensitivities. This is quite important. And we need to follow guidelines, which for us is a clinical and laboratory standard institute guidelines for AST and interpretation of breakpoints. We need to ensure we also have the current guidelines because they are being updated from time to time, actually yearly. And so again, I almost hammer on this, that appropriate controls need to be included to make sure that the quality of laboratory results are attained. So in concluding, we've seen that GBS is a major bacterial pathogen responsible for meningitis in the newborn. We've also known that proper handling, transport, and storage are prerequisites for obtaining high quality lab results. It's often said the quality of a laboratory result is dependent on the quality of the sample that is taken. So we need to be very, very proactive and intentional with this. I also want to repeat here that the gold standard for GBS diagnosis is culture. However, molecular methods have been well validated for timely detection and insightful description of serotypes and resistance features within GBS, giving a complete and full picture of the pathogen. And quality control measures must be included for all laboratory testing to assure the reliability, reproducibility, and timeliness of the results. And again, we just need to understand and be aware of the fact that laboratory data is the foundation of public health surveillance for GBS meningitis diagnosis. So we need to be intentional with this because it provides evidence-informed decisions for public health action. Thank you very much, and thank you again for listening.
Thank you, Catherine. Right on time. Congratulations. So, colleagues, let us now give chance to Prof. Andre Bitter to walk us through, the prevention and control strategies for GBS in our region for 10 minutes. Let me remind you that we have almost 30 minutes occasion to ask questions, but let us take this presentation from Prof. Andre Bitter on the prevention and control strategies. Thank you, Catherine, again. So may we have the presentation from Andre Bitter? Thanks. Okay. Thank you.
Hello, everybody. I'm just going to present these slides on behalf of Prof. Bitter, who's not able to make our session today.
Perfect.
Is that okay?
That's fine. Go ahead, please.
So building on the framework that we heard at the beginning of today's session, there are several prevention and control strategies for Group B strep meningitis, including, as I've mentioned, and as have others, a new effective and affordable vaccine, not only for Neisseria meningitidis and for pneumococcus, but also for GBS. At the same time, accelerating evidence-based policies for GBS infection in infants, along with the other major pathogens that cause meningitis. Specifically, member states should develop and implement appropriate vaccination strategies as these vaccines come online to improve vaccine uptake and ultimately increase protection amongst the neonatal population. Part of this work will entail intensifying meningococcal risk communication and community engagement and epidemic prevention and response. And specifically for Group B streptococcus, this will include discussing infections in pregnancy and in the neonatal period and working together with communities to improve vaccine acceptance around vaccination in pregnancy. At the same time, member states should establish the status of GBS disease within their regions. And as we've heard from Heidi, there are WHO guidelines for Group B streptococcal surveillance, which can be used for member states that are interested in doing so. As I said, a part of the work around Group B streptococcal meningitis will ensure that there is awareness among the populations of the signs and symptoms of infections during the neonatal period and when to seek care to reduce one of those key gaps in identification of cases that will prevent adequate surveillance for GBS. And this will include communication programs and activities at all levels, including population and healthcare workers, about the risks and signs and symptoms of meningitis and sepsis in the neonatal period, and a health-seeking response and community awareness of GBS, as there are for other neonatal pathogens such as tetanus. It's also really important that the communities understand the risks of meningitis and facilitate and those that facilitate health-seeking behaviour, especially in those first days to week of life, where we know that culturally and also because of our highly mobile populations, women may be less likely to seek care for an unwell infant. The Regional Implementation Framework to Defeat Meningitis 2030 in Africa sets out a plan to tackle the main causes of meningitis, which include GBS as a key pillar. And so these steps really need to be in place now, ready for a vaccine to be available by 2030. So the core indicators for GBS to monitor and evaluate, you can see here on the right side. This includes incidence, and as you will have heard, there are national and regional estimates of Group B streptococcal colonisation and disease within the Africa region. Vaccine coverage rates for Group B streptococcal vaccine when it becomes available, and the percentage of countries that have implemented routine immunisation programmes for Group B streptococcus. Importantly, the Group B streptococcal vaccine is part of the Gavi 6.0 portfolio and so should be available to countries in Africa when it becomes licensed quite quickly. There is also a need to understand the percentage of countries that have collected CSF or blood samples with at least 50% of suspected meningitis cases. And here a large amount of community and healthcare worker sensitisation is needed because we know there are several barriers to lumbar puncture amongst communities in countries in the region. We also need the percentage of alert or epidemic health districts which have investigated and documented any epidemics. And for Group B streptococcal epidemics, really the sentinel event is usually an increase of deaths in a neonatal unit. And you see this in middle-income countries where an infant has been transferred in from another hospital, and then there is an increased number of deaths both in the transfer out hospital and the transfer in hospital, but with very little microbiology, which is where, as we've heard from the previous presenter, these molecular techniques can be very helpful. There is a need for the percentage of countries to implement national and regional GBS prevention strategies, which mainly revolve around antibiotics in labour where that's available, and vaccination when that comes online, and the percentage of countries submitting specimens and epidemiological data from at least 10% of cases with meningitis within the global network. We also need to ensure that we collect the percentage of people who are affected by meningitis who've received care. And as I said, with up to 50% of infants going on to have moderate to severe developmental impairment, there is a real need to develop strategies to monitor and follow up these children in our settings. We also need to know the percentage of countries with community-based programmes available to support people affected by meningitis, and the percentage of countries with awareness campaigns appropriate to national burden and integrated within the existing health awareness activities. And it's very important for Group B streptococcal disease specifically that the antenatal care programme includes an element about Group B streptococcal disease and vaccines in pregnancy. But as you will have heard through all of these talks, there are several challenges, including a lack of coordination between programmes, specifically surveillance, laboratories, clinicians and health promotion, and within the different sectors such as families, the communities, social and finance. There's generally a lack of engagement with community, civil society and NGO in the fight against Group B streptococcal meningitis, specifically because of a lack of awareness of Group B streptococcal meningitis and neonatal meningitis more broadly, and a lack of capacity in healthcare workers to identify Group B streptococcus because it's not very well understood. We need to improve training in the identification of Group B streptococcus amongst healthcare workers, families and laboratories, and there is inadequate funding for the development and implementation of national plans to defeat meningitis by 2030, especially with the added complexity of inclusion in antenatal and neonatal care in the programme, and a lack of partners to support laboratory capacity strengthening. And as you have heard, there are several steps in the identification of Group B streptococcus that are needed to understand the true burden of disease. So in terms of perspectives, review of the SOPs on meningitis surveillance and preparedness for outbreaks to incorporate the surveillance within the integration of identification and management of GBS, which you will have heard Heidi Sutters talking about. Continue to support countries to incorporate GBS surveillance testing and management into their national plans according to the surveillance plans in order to defeat meningitis by 2030, whilst mobilising the resources for the development and implementation of these plans, and to conduct surveys to assess the burden of GBS disease in the African region. And I'll end my talk there. Once again, merci and thank you very much.
Thank you, Kirsty. Thank you so much for making this presentation on behalf of Prof. Andre Bita. Okay, so colleagues, now we have the floor for questions. Please just raise your hand and we'll give you the floor. And we also have the Q&A button to receive your questions. Let me see if we have any Ok, si vous voulez poser des questions sur toutes les présentations qui ont été faites, c'est l'occasion donc de poser ces questions, de lever la main et puis de poser ces questions. Merci à vous. Oui, docteur Soufiane Sanou, vous nous rappelez d'où vous nous appelez et vous posez votre question, s'il vous plaît. Merci.
Merci. Donc, je suis au Centre Miraz, en fait, au Burkina Faso, et je reviens avec une préoccupation pour les pays qui ont élaboré donc des stratégies de lutte contre la méningite d'ici 2030. Par rapport au financement de ces stratégies-là, qu'est-ce qui est réellement prévu? Comment ça doit se passer? Est-ce qu'il y a des conseils ou des pistes à proposer pour vraiment acquérir aussi rapidement que possible ces financements? Parce que 2030, c'est vite arrivé. Voilà. Merci.
You're on mute, Hilaire.
Okay, sorry. I was saying that Sanu has put a comment in the chat, so everybody's invited to read it there. Now, let me give the floor to Andre Arsene for your question. Sanu Soufiane, you can put down your hand now. Thank you. André Soufiane, André Arsene, à vous. Merci.
Non, merci beaucoup. Hein. Je m'excuse pour le réseau qui n'est pas bon. Est-ce que vous m'entendez bien?
Oui, parfaitement.
Ok, très bien. Merci beaucoup pour la question posée. Je voulais juste dire que l'OMS Afro et les autres partenaires se sont engagés pour pouvoir soutenir les pays dans la mise en œuvre des différents plans nationaux pour vaincre la méningite. Et d'ailleurs, même en octobre, il y aura un atelier au Burkina Faso. Je pense que dans le souci, déjà, c'est bien un effort. On félicite des pays qui ont déjà finalisé leur plan. Certains sont en train de finaliser les plans, mais surtout de renforcer les aspects de groupe Staphylococcus. Donc, de tout le conseil, nous allons ensemble voir les possibilités de pouvoir vous apporter un appui, que ce soit un appui technique ou alors d'autres appuis qui seront sollicités ensemble. On a également d'autres, des ONG et la société civile qu'on est en train d'intégrer qui sont concernés par cela. On fera connaître. Au Burkina Faso, effectivement, il y a des ONG qui sont connues et qui suivent ces aspects. Certains sont dans des enquêtes et on a quelques résultats. Donc, je veux juste confirmer que l'OMS Afro pourra apporter tout son appui aux différents pays, y compris les collègues qui sont dans les pays. Merci beaucoup.
Merci beaucoup, Prof. André Bita. Arsène, Augustin Karumba, now you have the floor. And apologies for the first time. We missed to give you the floor. Over to you, sir. Le son, excusez-moi, le son est très, très faible. Si vous pouvez parler un peu plus fort, ça nous arrangerait beaucoup.
Est-ce que là, vous me captez bien?
Pas du tout, c'est toujours très, très loin. Si vous pouvez vous rapprocher.
J'espère que là, vous me captez maintenant bien.
Super bien, allez-y.
Ok, en fait, je suis Augustin Karumba, médecin. Je suis Case Management Officer. Je vous appelle de Goma en RDC. En fait, ma question était concernant la prise en charge. Alors, je me demandais s'il y a un risque identifié chez la femme enceinte pendant la grossesse. Quelles sont les actions qui doivent être, est-ce qu'il y a-t-il un protocole spécifique pour les actions qui doivent être mises à place pour protéger le nouveau-né qui va naître? Et si, par exemple, après la naissance, il y a des risques identifiés chez le nouveau-né, par exemple, on a un prélèvement qui prouve que, par exemple, il y a des risques chez le nouveau-né, quelles sont les actions qui doivent être menées pour protéger afin que la femme ne développe pas la méningite? Merci.
Merci beaucoup, docteur Augustin. Je ne sais pas si vous prenez encore une question ou bien de laisser la possibilité pour les réponses. OK, prenons une autre question. Ça va nous permettre... OK, docteur Sampara Daouda, à vous la question et ensuite on va répondre aux questions. Merci.
OK, merci bien, monsieur le modérateur. C'était par rapport toujours au dépistage. Quel est l'examen idéal chez une femme enceinte par rapport au dépistage?
C'est noté votre question. Je vais prendre la dernière de Aïssata Kone. À vous, s'il vous plaît.
Le sang. Vous me recevez, oui, ok.
Parlez
Ok,
un peu plus
merci,
fort.
vous me recevez.
On vous reçoit. Parlez un peu plus fort. Merci.
Ok, merci beaucoup, en fait. Oui, ok, merci. Au fait, ça va être plutôt une contribution qu'une question, parce que vu la difficulté quand même de faire le test, le liquide céphalo-rachidien, le prélèvement du liquide céphalo-rachidien chez le nouveau-né dans le contexte africain. Je pense qu'il serait mieux pour renforcer les stratégies de prévention de mettre l'accent chez la femme enceinte. Comme Augustin a eu à le dire, voir s'il y a un protocole pour la prise en charge et comment protéger que l'enfant ne fasse le Streptococcus galactiae du groupe B. Et également voir comment vraiment on pourra faire un prélèvement chez la femme enceinte. À quelle période nous pouvons vraiment faire un prélèvement chez la femme enceinte pour protéger l'enfant. Merci à vous.
OK, merci beaucoup. Je propose qu'on... André a la main levée. C'est une ancienne mère ou c'est une nouvelle mère, prof. André Bita?
Oui, merci. Je vais répondre parce que je risque de plus avoir le réseau. Et Catherine va certainement, docteur Catherine va répondre par rapport au prélèvement. Non, je voulais d'abord dire que 60% des décès néonataux sont causés par le groupe Streptococcus et l'Afrique compte plus de la moitié du fardeau mondial. Il faut dire que dans certains pays, je l'ai mis dans le chat, on envisage faire une antibiothérapie avant, 6 heures avant l'accouchement. Mais actuellement, il y a un vaccin qui est en cours de fabrication, de développement et qui certainement va beaucoup aider. 20% des patients, surtout en Afrique, portent le germe, mais sont asymptomatiques. Donc, c'est très difficile. Alors, le plus souvent, dans les infections néonatales, et vous avez vu que la description clinique correspond souvent à la description qui est donnée pour la méningite dans les infections néonatales. Et beaucoup, malheureusement, on traite, mais on ne sait pas spécifiquement qu'il s'agit d'une méningite due à Gobi Staphylococcus. Dans les enquêtes, comme vous avez vu dans les perspectives qui seront faites, le fait qu'on introduise dans la surveillance et l'OMS, et je complète ce que je venais de dire tout à l'heure, l'OMS va partager, va supporter les pays pour avoir les réactifs, pour aider à faire le traitement, mais surtout le diagnostic. Et c'est pour cela que ce webinaire, par exemple, entre dans cette action de commencer à promouvoir cela et, comme on dit, encourager à mettre dans vos plans. Donc, il y aura un support dans la formation, dans la distribution des réactifs, mais surtout dans l'accompagnement du pays pour pouvoir mieux cerner le poids. Comme je disais, une antibiothérapie avant, mais surtout les antibiothérapies adaptées aux infections néonatales pour pouvoir réduire donc ce poids et améliorer l'état de vie. On espère que très rapidement, on aura un vaccin qui va permettre de protéger les enfants à travers la maman et puis plus tard de réduire ce poids. Merci beaucoup à vous.
Merci beaucoup, Prof. Andrebita. Now, Catherine, do you have any responses to provide to question asked?
Yeah, I didn't quite get the question, please.
Okay, there were a lot of questions on the detection. What was the ideal test to take from Dr. Sempara from my notes? But I think that Andre has already given an answer to that. And a question from Dr. Kone. She said that the pregnant woman, it is difficult to do a lumbar puncture from the newborn. So she proposed that the stress is put on the pregnant women. Now, when ideally should the puncture be taken from the pregnant woman, for instance, from Dr. Isafa Kone?
Okay, so thank you very much for the question. The lumbar puncture is not taken from women, it's taken from the neonates. So from the women, what is actually taken, and I heard Kirsty talk a little bit about that, it's the vaginal swab. So the doctor takes a vaginal swab, and the vaginal swab, I pointed out in my presentation that it shouldn't be Dacron or cotton. There are fluff swabs that are used for these specific ones because this is what actually enhances the release of the microorganism from the swab. From the children is CSF that is taken. I heard Professor Bita talking a little bit about this. And it's taken when the doctor actually suspects that the neonate has meningitis, and the CSF, a lumbar puncture is taken. It should be taken by somebody who is quite knowledgeable and experienced in taking it. It should be taken under aseptic conditions. And in my presentation, I hope you are going to share the slides. I'd already said when the CSF should be taken to the lab within 1 hour after a lumbar puncture is made. If a lumbar puncture is made and the CSF cannot be taken to the lab, the CSF should be inoculated into a trans-isolate medium and taken to the lab within 24 hours. And if it cannot be cultured immediately, it should be incubated at 35 to 37 degrees centigrade in some amount of carbon dioxide, specifically 5% of carbon dioxide, and then monitored and observed daily for growth and turbidity in the biphasic medium. I don't know if that clarifies her question, but it should be noted that the CSF is not taken from mothers because GBS is gotten by the neonates through vertical transmission. So it's a swab which is taken from the mother and then a CSF from the neonate. However, swabs can also be taken from neonates. I showed how the nasopharyngeal swabs are taken and also interrogated for GBS infection. Thank you very much.
Thank you, Catherine, for addressing these questions. Let me see if we still have questions to in the chat or in the Q&A. Alors, s'il y a des questions à poser.
There's a hand by Augustine Karumba.
Yes, Karumba, again, give you the floor. Over to you. À vous la parole, s'il vous plaît, docteur.
Ok, ma question, mon observation se trouve dans les lieux les plus reculés souvent, où on a d'abord la problématique de trouver quelqu'un qui est expérimenté dans le prélèvement, surtout la ponction lombaire, mais aussi dans la nécessité de la prise en charge, puisque plus vous avez des signes de méningite, il est nécessaire de commencer le plus rapidement une antibiothérapie probabiliste. Alors, là, la question là maintenant, je pense qu'il y aura toujours des difficultés d'avoir des données. Des données, par exemple, ou bien des données parce qu'avec l'antibiothérapie qui est déjà fait d'avance, on peut avoir difficilement des cultures qui vont être positives. Alors, dans ce contexte-là, quelles sont les actions qu'on peut mettre en œuvre pour permettre de limiter cette question-là? Merci.
OK, merci beaucoup, docteur. Oh, Catherine, sorry. You've heard the question from Dr. Augustine. Would you like to respond right away? Thank you.
For some reason, I can't hear the participants clearly. I didn't hear the question. Yeah.
Sorry. Okay. He said that it is hard to find someone who is experienced, to do the lumbar puncture. So he understood that an antibiotic therapy should be put in place, but the data will be hard to get. So what actions would you propose to take to, give the chance to the women to avoid the GBS? Roughly, this is what he said.
Okay, this is good. I know very well in our region, culture of GBS, the awareness is really not there. Mostly because lumbar puncture is so difficult. It's really difficult in our region to understand suspected cases and get a lumbar puncture. For most of the times, you don't even have the infrastructure like the lumbar puncture kits, even when the experienced persons are there. So if you think, and this is what is done in some of the healthcare centers now, once a clinician suspects that a neonate has meningitis, whatever the causative agent is, they go ahead and treat with antibiotics. So in those situations, you will actually lose the pathogen. You would not be able to do an antibiotic susceptibility testing. You will not be able to store your isolates as it should be, that it can provide, knowledge to the vaccines that are being developed, as Kirsty talked about. But then one way to circumvent that is to do molecular testing, because like I said in my presentation, where you have prior antibiotic, reception, you have poor storage to samples, poor handling of samples, you will definitely lose your specimen. If GBS is in the specimen, you obviously lose it. But then you can now advance to molecular methods like PCRs, where you can, harvest the nucleic acid, and then you'll be able to identify what the causative agent of the disease is. And that's the only way you can get GBS if it was there prior to taking of antibiotics. So this awareness is so important so that we also let our doctors know when to take the lumbar puncture. We need to know when to take the sample to the lab. We need to know when to culture it. And if we cannot culture it, we can also do other tests. A gram stain, which is simple and inexpensive, will give you a clue. It will tell you this is a gram-positive cocci, and then you start suspecting. You can even do a rapid diagnostic testing, which will also give you a presumptive diagnosis if you can't do a culture and if you can't move up to, a PCR. Thank you very much.
Thank you, Catherine, for giving all these clarifications. Andres Vida's hand is up, maybe for complementary.
Yes, thank you. Thank you very much, Ida. Thank you very much, Dr. Catherine, for this information. I would like just to say that WHO is producing and providing trans-isolate media that help to really have conserve these pathogens and send to the reference lab for testing. The second point is about raise awareness of clinicians, gynecologists, pediatricians, lab, and all the epidemiologists about these traits when it comes to GBS. And then we will really try to organize trainings, providing equipment, providing also reagents, and make sure that we really move to increase or to improve GBS testing, but really care when it comes to meningitis. Just to say that when you suspect meningitis case, you have first of all to start the treatment, ceftriaxone. Maybe you can collect this CSF sample, as Dr. Catherine was saying. You can collect and then you can do this molecular testing, PCR. So it's very important when you suspect to start without waiting, having this CSF sample collection, and then then after you can readjust, you can adjust your treatment following the result. Thank you. Over.
Thank you, Prof. Andre Bita. Okay, let us see if we still have questions from the audience. Does anyone have any question? Okay. If any panelists want to, provide our audience with any other significant answer.
Yes, I don't know if I can just say something before wrap up. It's just to say that thank you first of all to all the facilitators, participants. I think that is the first webinar on GBS. We'll continue to provide maybe in-person workshop and make sure that people are really aware but really knowledgeable to strengthen these traits, these battles against meningitis, and be aware. Can you imagine 60% of neonates are died because of GBS, and we are not really aware on that. So our really task is to continue to support the countries, but in the countries to be aware and to develop their policies in order. And we are all the partners engaged in the battles against meningitis. We are all committed to continue to support and to really help the country. Don't hesitate to provide any question, to request anything, and then we'll all together move forward to really reduce or to defeat meningitis by 2030. Thank you very much. Over to you, Ile.
Thank you, Prof. Andre. Yes, before we close, we have a question maybe from Andre Denis. À vous la parole, s'il vous plaît. Dites-nous d'où vous connectez. André est parti. Oui,
I'm still there.
Allez-y, s'il vous plaît.
Oui, bonjour à tout le monde.
Bonjour.
Oui, vraiment, merci déjà pour ce travail que vous faites déjà pour nous. S'il vous plaît, ma question revient à la microbiologiste qui a présenté sur les analyses du GBS au laboratoire. Je voudrais juste savoir, est-ce que nous pouvons avoir, ou alors est-ce qu'il y a des procédures standards pour la détection, l'analyse du GBS à des niveaux différents, dont périphérique, intermédiaire et central, pour pouvoir déjà essayer de faire quelque chose avant de penser à la culture. Puisque dans le contexte africain, nous savons comment nous avons d'abord un sérieux problème de plateau technique. Merci beaucoup. C'est ce que je voudrais savoir. Est-ce que nous pouvons avoir des procédures standards?
Okay, thank you. Catherine, in case you haven't gotten the
Yes,
translation.
no, I have. I heard
Okay.
him very well. I heard him very well.
Please proceed.
So talking about the standard operating procedures for GBS meningitis, we have already seen during the presentations that this is one of, the pathogens that causes neonatal sepsis and meningitis. And because it causes meningitis, its diagnosis is as similar as that of Neisseria meningitidis, Streptococcus pneumonia, and Haemophilus influenza, talking about the different serotypes and the different serogroups of all of those pathogens. In there, we still have other pathogens like Listeria monocytogenes and all of that. So there are some standard operating procedures that are all included in the WHO guidelines that one of my colleagues, I think it was Heather, also talked about during her presentations. But those guidelines are going to be updated specifically for GBS. I also know that the American Society for Microbiology also has some guidelines, standard operating procedures that deal with GBS from, pregnant women, talking about all the stages of the pregnant women and when, the vaginal swabs can be collected, how they should be collected, how they should be transported, and how they should be stored, the different media to use, and all of that is, is in place. However, Heidi had said during her presentation that the WHO guideline for the diagnosis of the 3 pathogens I'd already mentioned, that will be updated with the guidelines and standard laboratory procedures for GBS. So once that is done, I think all of those protocols will be harmonized so that participants, colleagues, laboratorians, all the people who are involved with work on GBS can have a unified and harmonized protocol to use. But all the protocols are, they are just like those for diagnosing the other 3 pathogens that are the main bacterial pathogens for meningitis beyond the newborn period. The agar in the lab or the culture media, the equipment, the infrastructure, they are all the same. So it will just be a little bit of tweaking here and there on conditions like temperature, conditions like the type of medium to use, the type of differential medium to use, and all of that. So it will not be a lot more different than what we already have. Thank you very much.
Thank you so much, Catherine. We are just, I think, 5 minutes ahead of the due time, but I think we can wrap up now. So I'd like to thank all the panelists, Andre Bita, of course, Anders Sonlat, Kirsty, Heidi, and you, Catherine. Thank you also to Amarashi for the technical aspects. Let me just remind you that the presentation will be shared later on, so you don't need to worry at all. Also, you can still register. We have a link that I've shared earlier. So if you're interested in webinars, we have a channel on YouTube. The link is there. And please get registered and you will get every webinar we've run so far. So thank you, everybody, and see you next time. Bye-bye. Merci beaucoup à tous. Bye-bye.
Merci. Au revoir.
Au revoir. Bye-bye. Thank you.
Bye.
Merci. Well done. Merci.
Merci.